Welcome back, guys. So what is your today's topic in endocrine physiology? So our today's topic in endocrine physiology is one very important topic, and that is regulation of calcium levels, also known as calcium homeostasis. Very important. So why we are discussing this calcium regulation in endocrine physiology, sir? Because this calcium regulation is totally hormonal, right? So with this important note, so in calcium homeostasis, now we are going to discuss about the forms of calcium. So see here, sir, very important. The normal calcium levels are 8.7 to 10.2 milligram per deciliter. 8.7 to 10.2 milligram per deciliter is the normal calcium levels. This is also our target in calcium homeostasis. So see here, now I'm going to split this total calcium into two parts. One, the 50% of calcium is present in free form, also known as active form and ionic calcium. And we know in endocrinology that only the free form and active form is present for axons. Right? Now, the remaining 50% of calcium is present in bound form. So what binds to this calcium, sir? Very important protein, albumin. This albumin binds to this calcium, and that's why the 50% of calcium is present in bound form, also known as inactive form. Now see, sir, very important. This free form and bound form of calciums. So the levels of this free form and bound form of calcium are determined by two very important factors. What are those factors, sir? The pH of blood and albumin. Blood pH and albumin, these are the two very important factors which determine the percentage of free and bound form of calcium, especially the blood pH. So now with this important note, now see here, very important, the blood pH. So whenever there is decrease in blood pH, especially in states like acidosis, there is increased H plus ions, and these ions binds to this albumin. Very important. That's why there is increase in free form of calcium, and that leads to hypercalcemia. So see here, in acidosis, there is decrease in pH and increased levels of H plus ions. Now these H plus ions wins the race and they bind to this albumin on place of calcium. That's why there is increase in free form of calcium that leads to hypercalcemia. Now see, sir, on the other hand, in states like alkalosis, there is increase in pH, decrease in H plus ions. That's why more calcium binds to this albumin, right? That's why increase in bound form of calcium and decrease in free form of calcium, that leads to something called hypocalcemia, and the patient manifests with something very important, tetany. So in acidosis, decrease in pH, right, and increase in the free form of calcium, that leads to hypercalcemia. In alkalosis, increase in pH, decrease in H plus ions, that's why increase in the bound form of calcium, that leads to hypocalcemia and manifest with tetany. Very important. So with this important note, so in calcium regulation, now we are going to discuss something very important. What is that, sir? So see here, this magic number 3. So what is this magic number, sir? So in calcium regulation, there is something known as 3 hormones, 3 organ models, sir. Very important. So see here, what are those 3 hormones which regulate the calcium levels? So see here, the first one is parathormone, the second one is vitamin D. So these first 2 hormones, parathormone and vitamin D, they are considered to increase the calcium levels. The third one is calcitonin, which decrease the calcium levels. So how to memorize, sir? It's very confusing. So see here, this calcitonin, calci means calcium, IN means inhibitor, right? The hormone which inhibit the calcium levels, that is calcitonin, right? So see here, the 3 hormones are parathormone and vitamin D. These 2 increase the calcium levels, and the third one is calcitonin, which decrease the calcium levels. Very important. Now, sir, what are the 3 organs which regulate the calcium levels? So see here, the first one, very important, sir. What is that? Our bone. Why important, sir? Because this is also known as the bank of calcium. Why, sir? Because whenever you have excess calcium, deposit that calcium to this bone. Whenever you have less calcium, take from this bone. Very important. The second one is our GIT, gastrointestinal tract. The third one is very important, our kidney. So The three hormones are parathormone, vitamin D and calcitonin, and the three important organs are bone, GIT and kidney, right? This is the three hormones, three organ model for calcium regulation. Now with this important note, so in calcium regulation, now we will see all these three hormones one by one. So the first one is parathormone over PTH. So what is the source of this parathormone, sir? Which gland? So one very important gland, the name is parathyroid gland. So very specifically the chief cells of parathyroid gland which produces parathormone. Now sir, very important. The structure of this parathormone contains 84 amino acids. Why this is important, sir? Because of these 84 amino acids in the structure of parathormone, this is also considered as protein hormone. Very important. Now sir, by using certain drugs, we can produce the action of parathormones. So what is the drug form of parathormone? So the drug form of parathormone is teriparatide. Using this teriparatide, we can produce the actions like parathormone. Very important. Now sir, now we will see the actions of parathormone. So first we will see on the bone. So we know that in bones we have two cells. One is osteoclast and the second one is osteoblast. So out of these two cells, on which cell the parathormone receptors are present, sir? Osteoclast or blast? So see here, osteoblast. Parathormone receptors are present on osteoblast. So when this parathormone will bind these parathormone receptors on osteoblast, this osteoblast will produce something called very important rank ligand. Now this rank ligand will go to this osteoclast and will induce the differentiation of osteoclasts. That's why there is increase in the osteoclast activity and that leads to bone resorption, right? Parathormone act on osteoblast, produces rank ligand. This rank ligand induces the differentiation of osteoclast. That's why there is increase in osteoclast activity and that leads to bone resorption. Now with this important note, so now see the clinical correlation. Till the time we have seen that our rank ligand, they induces the differentiation of osteoclast. That's why there is increase in osteoclast activity, sir, and that leads to bone resorption, ultimately osteoporosis. Now see here, sir, we have something very important called rank ligand blocker. What are these rank ligand blockers, sir? These are some very important monoclonal antibody. The name is denosumab. So we use this denosumab to prevent bone resorption in osteoporosis. Very important. Now see, sir, we know that our osteoclast cell, they causes bone resorption. How, sir? With the help of this very important enzyme, acid proteases. By using this very important enzyme, acid proteases, our osteoclast cells causes bone resorption. Now, whenever our calcium stores, it never stores alone. It always stores with phosphate in the form of crystals. And the name of these crystals are hydroxyapatite crystals. Now very important. Our osteoclast cell, with the help of this very important enzyme, acid proteases, destroy all hydroxyapatite crystals and results in increased calcium and phosphate levels. So till the time we know that parathormone receptors are present on osteoblasts. Then these osteoblast cells, they produce rank ligand. Then this rank ligand act on osteoclast and causes bone resorption, and that's why there is increased level of calcium and phosphate. That's why the function of parathormone on bone is increase in calcium and phosphate. Very important. So now with this important note, so till the time we have seen the actions of parathormone on bone, our first organ. Now we will see our second organ, that is our kidney, sir. Very important. This kidney is responsible for the overall action of parathormone. Now see how. In kidneys, this parathormone increase the calcium resorption by acting on the distal convoluted tubules DCT. At the same time, it also increase the excretion of phosphate by acting on the proximal convoluted tubules PCT. How, sir? In PCT we have something very important protein channel, that is sodium phosphate cotransporter. So by inhibiting the sodium phosphate co-transporter, this parathormone increase the phosphate excretion, right? So we know that hormone that decrease the calcium levels is known as calcitonin. Now the hormone which decrease the phosphate level is known as phosphatonin, in the same line. Now see sir, now we know that our parathormone increase the calcium resorption and increase the phosphate excretion. Now see, this parathormone is also known as phosphate terminating hormone and phosphatonin. So how to memorize this? Parathormone hormone, PTH. So see here, parathyroid hormone, parathormone, P means phosphate, T means terminating, and H means hormone. So our parathormone or PTH hormone is also known as phosphate terminating hormone, phosphatonin. Very important. Now the last organ is our GIT, gastrointestinal tract. So in GIT, our parathormone have indirect actions. How sir? In GIT, this parathormone increases the vitamin D. This is the only form of hormone in GIT which can increase the calcium absorption. So by increasing the vitamin D into GIT, our parathormone increases the calcium absorption. Very important. Now sir, the overall action of parathormone is increase in calcium and decrease in phosphate. Very important. So now with this important note, so after parathormone, the second hormone that we are going to discuss is vitamin D. So see here sir, for the synthesis of vitamin D, we need certain precursor, and these precursors are 7-dehydrocholesterol present in our skin. Now sir, for the synthesis of vitamin D from this precursor, our sunlight, especially the UV B rays, ultraviolet B rays with the wavelength of 280 to 320 nanometer need to be act on these precursors. When the sunlight, the UV B rays act on this precursor, they converts into vitamin D3 in our skin. But still this vitamin D3 is in inactive form. Now sir, this vitamin D3 will move to our liver. Why sir? Because in liver we have an enzyme 25 hydroxylase. Now this vitamin D3 will be converted into 25 hydroxy vitamin D. Again, this is in inactive form. Now see here, very important sir. If we want to know the status of vitamin D of one individual, we can assess the levels of 25 hydroxy vitamin D3. Very important. Now this 25 hydroxy vitamin D will move to our kidney. Why sir? Because in kidney we have one very important enzyme, 1-alpha hydroxylase. This enzyme will convert the 25 hydroxy vitamin D into the most active form of vitamin D, that is 125 dihydroxy vitamin D3, also known as calcitriol. So the form of vitamin D which is present in kidney, the calcitriol is the most active form of vitamin D. Very important. Now with this important note, so now we are going to see the actions of vitamin D. And the first organ is our GIT. So in GIT, where this vitamin D will act sir? So see here, vitamin D, D for duodenum, D, right? So vitamin D will act on duodenum. That's why calcium is absorbed more in duodenum. Now sir, this vitamin D in our duodenum will form one very important protein. The name is calbindin. This is one calcium binding protein. So now whenever one calcium rich food will reach to this duodenum, this calbindin will bind to that calcium and will increase the calcium absorption from duodenum. Very important sir. Now see this second organ, that is our bone. So vitamin D receptors are present on osteoblast. Like parathormone, the vitamin D receptors are also present on osteoblast. Now sir, these osteoblasts will produce rank ligand. This rank ligand will induce the differentiation of osteoclast cell, not blast, osteoclast cells. Now sir, because of this differentiation, there will be increased osteoclast activity, and that will increase the bone resorption, means increase in calcium and increase in phosphate. So you can see here the action of both parathormone and vitamin D is similar on bone. Very important. Now sir, the third organ is our kidney. This is one very important area for MCQ. Why? See here. Our vitamin D increase the calcium resorption from DCT in our kidney. Similar. What our parathormone does, the same action is vitamin D is doing here. Increase in calcium resorption from DCT. Now sir, very important. Our vitamin D increase the phosphate resorption, where our parathormone, the parathyroid hormone, increase the phosphate excretion. This is the difference. So now see here, the overall action of vitamin D is increase in phosphate and increase in calcium levels. Very important. So now with this important note, so now we are going to see the third hormone. What is that hormone, sir? Calcitonin. What is the source of calcitonin? The parafollicular C cells of thyroid gland. Parafollicular C cells of thyroid gland are the source of calcitonin. Very important. Now sir, we can also produce the action of calcitonin using certain drug forms. What are those drug forms? So those drug forms of calcitonin are, see here, very important, salcatonin. The source is salmon fish. That's why the name is salcatonin. Now we will see the actions of calcitonin. So see here, the first organ is bone. So the calcitonin receptors are present on osteoclast. Remember our parathormone and vitamin D? The receptors are present on osteoblast, but calcitonin receptors are present on osteoclast. That's why our calcitonin inhibits the osteoclast activity and prevent the bone resorption. In result, it decreases calcium. Very simple. Now sir, the second organ is kidney. So our calcitonin increase the calcium excretion. That's why it decrease the calcium again. Very important. Remember our parathormone and vitamin D, they increase the calcium resorption in kidney. So see here, these both the actions are tend to decrease the calcium. That is the function of calcitonin, the inhibitor of calcium. Now sir, now we will see something very important, the clinical correlation. So in pathological condition like tumor of parafollicular cells, right, generally seen in medullary thyroid carcinoma and medullary carcinoma thyroid. That's why there is excess calcitonin secretion, right? That's why this calcitonin is also used as tumor marker for medullary thyroid carcinoma. Very, very important. So now with this important end, so now we are going to discuss something very important. What is that, sir? Malignancy induced hypercalcemia. Hypercalcemia of malignancy. Very commonly seen in lung carcinoma, and it occurs as a part of tumor. That's why called paraneoplastic syndrome. Very important, sir. So what lung carcinoma, sir? So squamous cell and small cell lung carcinoma. So what causes this hypercalcemia here, sir? Is that parathormone? So don't be confused. This is the PTR, the parathormone related peptide. So in lung carcinoma like squamous cell and small cell carcinoma, there is secretion of PTR, the parathormone related peptide, that increase the calcium levels and induce hypercalcemia. With this important note, so thank you so much friends for watching, and please do subscribe the channel and also give your important feedback in the comment section. Hope you learned something from this new series, Study With Me, the whole endocrine system in less than 2 hours. So stay safe, stay happy, study a lot. Thank you so much. Have a great day.